Good afternoon, everybody. A case black cataract or hard cataract, it is everyday practice in Upper Egypt. Here I prefer to implant malleolar ring to support because I need to have average size pupil all time surgery, large rexes, everything is going well, nothing except it is a little bit hard. The routine technique of large exposed tape, extended divide and conquer, debulking of the whole nucleus after soft shell technique, removing the core of the nucleus in the leg, so protected by the endothelium with using ultrasound modalities of the machine to make things safer on the cornea. After removing this very hard nucleus, very tough, things are going well. Next case is ready. At this step, as you see, please. Sudden. Now, there is opening in the posterior capsule, as you see. Things are centered round and opening in the center, so injection of dispersive OVD. Dispersive, not cohesive, it's better here. Inject and keep injecting. To tamponade the anterior vitreous face, I always pressurize it. Don't go out. Never run away. Keep injection. More. Here, maybe take the decision. There is rupture of posterior capsule, dense particles. Do you prefer ultrasound? Do you prefer to risk of suppression, open the incision, or use another technique?
What about using scaffold technique just in front of your eye?
Yes.
Think about this.
That's I made. I followed your orders. I inserted my 3-piece IOL into the anterior chamber in front of the eyes to support, trying to centralize it. Good. Securing the lens particles in front of the IOL to be protected from falling away into the vitreous. Centralizing the IOL. Now, slow motion phaco and removing these hard particles with OVD. Things are not good. There is instability of the anterior chamber, as you see. Oops. Looks, there is a vitreous prolapse. As you see to the side in this area, there is vitreous prolapse. So I stop, inject OVD. Vitreous is coming, so I pressurize it. Swimming is better. Definitely there is a vitreous. So go with vitrectomy, cleaning the vitreous. I'd like to inject triamcinolone, cleaning vitreous. Now, removing the small particles with the capsulexis forceps. Everything is okay now. I reposition this IOL in the sulcus. The challenge here is the presence of the malleolar ring. As you see, I am repositioning the haptic. One, the leading haptic, now it is at the sulcus. I rotate the IOL, it doesn't rotate. Reposition. It looks as the haptic is entrapped in the eyelid of the malleolar ring. It's a problem. Remove the malleolar and get now pupil, or keep it drying and the pupil is dilating around the limb, I think.
I think we would remove the malleolar ring before implantation of the IOL to work, because the image now you will have the benefit of no pupil, and then after implantation of the IOL you will have complete discovery. But here, because you are inserting the malleolar ring under the IOL so that you have some spaces where it is dangerous for the...
But if you remove the malleolar ring, you will get a very narrow pupil. You
Yes,
can't not sure in the sulcus. Maybe you go away.
You have a good access.
I don't know. So,
Okay, just a comment. When you first open, then the scaffold technique, okay, but you should, in my opinion, there was vitreous from the beginning. I wouldn't go with the phaco again, and it was particles. I would use to make first to make sure, as you did sweeping at that later on, to make sure where are the strands of the vitreous, and then with the capsular axis forces, I will get these particles. Not to do phaco with fluid going with the open capsule and vitreous already collapsed.
until I made the scaffold, there is no vitreous. I'm sure. But while I start fluid, vitreous is coming at this time.
I'll just make a couple of comments. I think the cause of the capsule problem, I think, was the fact that the second instrument was in the eye. That tends to destabilize the anterior chamber. So usually, I would remove the second instrument if I'm not using it. You were using it because it's such a hard cataract. But if you take it out, often the pieces will come to the phaco probe. But once it's happened, then I would always use triamcinolone to make sure that there's no vitreous there. If there's not, you can do what you've done. If there is, you then have to do a vitrectomy a bit earlier. But once you've put viscoelastic in, you can't put triamcinolone in, so you then have to do a viscoelastic triamcinolone exchange, or a viscoelastic BSS exchange, and then put the triamcinolone in. But I think unless you put triamcinolone in, you can never be 100% sure that there's no vitreous there.
I totally agree with you, but for the first point, it is the instrument at this point was forward spatula, not the shoulder. And it's difficult to it's opened by ficotable, definitely instability, and it is the rounded opening of the ficotable, it's a mistake. Now, I tried to disengage the haptic from the macular ring and reinserting it. Now, as you see, sure, it is disengaged. It is in now again in the anterior chamber to entering bilaterally to push the IOL posterior, and I succeeded to put it in the sulcus in front of the anterior axis. Sure, there's some bleeding occur, no problem. If I'm bleeding at this time, rotating. When it is not entrapped to the eyelid, it rotates easily and be supported, well centralized. Removing macular, irrigation aspiration, moving the OVD. Sure, I didn't go behind the IOL at all because I have open posterior capsule, except if I go with a cutter, pressurize the eyeball up to the end with the hydration of the wounds. Fortunately enough, thanks God, after 2 weeks, the eye is quite clear and the pupil is reactive, the patient is happy and me happy, but my coronaries are not happy. Sure, I lost some of its vacancy.
Thank you very much, Hatem. I think it was a horrible case, but you did it very well. So for the sake of time, we will move for the next speaker.